Breech Birth podcast will be a little different. I'll be speaking with researchers, midwives, and obstetricians working within the breech birth space, bringing additional perspectives, knowledge, and evidence-based research to you, the listener. I hope you enjoy these conversations. Hi, Dr. Stuart Fischbein. Welcome to the podcast.
Hi, Sasha. Thank you. Thanks for having me on. Look, I always love talking to podcasters from other places and an audience that might not normally hear me. So thank you for this opportunity. Appreciate it.
Yeah, thank you. Very grateful to have you on the show. So before we jump into the questions, would you mind sharing a bit about yourself, your background, for anyone that might not know who you are, and particularly the breech world? And I know you've also supported twins. So we do have a lot of mums following that have had twins or having twins and triplets. So would love to hear a bit about your experience with those as well.
Sure. I'll try to stay focused a little bit. I know it's a day later where you are, but to anybody listening, happy St. Patrick's Day. I got my green underwear on. I got my green socks on. I even have my green shirt on today. So I'm not Irish, but everybody's Irish today. I'm Stuart Fischbein. I grew up in the Midwest in Minnesota of the United States. I went to medical school in Minnesota, and people may not understand how that works, but the first 2 years of medical school, this was back in the 1970s, so it's a long time ago. I don't think it's changed that much, are usually classroom and laboratory, including anatomy lab. And the second 2 years, you generally do rotations on different services. Some are mandatory required, like surgery, OBGYN, internal medicine, pediatrics, and some are elective, like ear, nose, and throat, neurology, dermatology, those sorts of things. I had just come off a rotation on blood cancers called hematology oncology. And my next rotation in my third year was OBGYN. It was random. Again, a lot of things led me down this path you could never have predicted. They're not something that I was inspired to do birth because I was 3 years old and I saw my mom give birth. Like a lot of midwives I talked to, they have that story and they knew from very early on. I did not. I just happened to really like the idea of catching a baby in the middle of the night. And I really wanted to do one of the specialties that had longitudinal care, which is taking care of a woman or a patient over time. And there's only 3 specialties that do that, and that's internal medicine, family practice, OBGYN. And I liked surgery. And with OBGYN, you get to do a little bit of endocrinology, a little bit of family practice, a little psychology. You get to catch babies. You get to do surgery. You get a wide variation. So I found it very interesting for me. And of course, you're making this decision, Sasha, at a time when you really don't know anything. You're a young kid in your early 20s. You don't know anything, and you got to make a decision that's sort of committing yourself to a life that you may or may not like down the road. And I would say that a lot of my colleagues who chose OBGYN are probably not real happy these days, but they're kind of stuck on that train. So I matched my residency in Southern California. And part of my training, I was at Cedars-Sinai Medical Center, and part of our training was affiliation with LA County USC Women's Hospital, which stands for Los Angeles County University of Southern California Women's Hospital. In the early 80s, it was the busiest hospital in the United States. They were doing about 22,000 births a year there, which is about 65 babies a day. And I was there for 4 months, and I was there every other day for 4 months. So you can do the math and you can see we got really exposed to a lot of things obstetric. Now, it was very medicalized in those days. Every woman was on her back. Most of them spoke Spanish. I didn't really speak much Spanish. The nurses just called us in when we were supposed to do something. It was very medicalized, mechanized birthing, but you got to see a lot. And you got to do a lot. And one of the things we saw every day were breech deliveries and twin deliveries. We did not consider them abnormal. We were not scared of them. As a matter of fact, we used to like them because they gave us some variety in our otherwise mundane day of catching head down babies. And I know anything that you do 20 times a day gets to be mundane, even though it's still bringing life in the world and that sort of thing. As residents, you get really cynical. All you want to do is finish your day and get out of there and go home and sleep for 12 hours and come back and do it all over again. So you get beaten up, you get very cynical, but we were exposed to the normalcy of breech birth as it was in that time, which was every woman was on her back. And once a breech baby was grabbable, you'd grab the baby, you'd do the maneuvers, and you'd get the baby out. But again, as I said earlier, you didn't see this pathology. So I finished my residency program like every other OBGYN resident. I was very medically trained, thinking that I knew everything because I was from a very good program. And I opened up a private practice. It was, again, medicine was different back in the mid 80s. People didn't come out like they do now, generally get a job, work a shift, get paid a salary, that sort of thing. You had to hustle and build your own practice. And one of the things I did to build my practice was I covered other doctors on call. I covered free clinics. I covered other labor and delivery units, working a shift there just to try to make some money while I'm trying to build my practice. And one of the fortuitous things that happened to me was being approached by some local midwives and asked if I would take their home birth transports. Why did they approach me? Partly because I was probably approachable, probably because I was a young buck looking for work. And they knew that. And so it was a really nice timing for things. And I said, sure. But I didn't say sure because I thought home birth was a good idea. Probably didn't know much about it. Only thing I knew probably was what my colleagues were telling me, which that it's crazy. And, I didn't know anything really about midwives either. I did it because it was going to generate revenue for me at a time where I needed to build a practice. But it was very fortuitous because as the patients came in, I began to realize that these aren't emergencies. They're just women who are exhausted or tired who need help. Every now and then there was a problem, but that's typical of labor in general, not home birth. And the midwives would come in and I'd have time, since I wasn't busy in the office yet, to sit around and to chat with them while we're waiting. The woman would get an epidural. We'd let her sleep for a while before we started Pitocin, or what you guys call Syntocin, and get them generally to go on and deliver vaginally, sometimes with a vacuum, sometimes they need a C-section, but there'd be a lot of downtime. And I would spend time talking to the midwives and learning about how they did things. The questions that a lot of dads ask, like, well, what happens if she starts bleeding? What happens if this happens or that happens? Because I didn't really know. And they would ask me questions like, why do you do it this way? Why do you do that? Why is the woman on her back? Why are you cutting the cord right away? Why is the baby going over to the warmer? Simple questions like that I had to look at myself in the mirror and say, I don't know. I don't have an answer for that. I'm doing it because that's what I was told to do. Never really thought about it. Really doesn't make any sense. And yet in most hospitals, that's still what they do. So they haven't changed in 50 years, 45 years. So I began to see things another way. And I began to realize that the midwifery model had a lot more sense to it as far as normal birthing goes than what I knew. What doctors are really good at is pathology. So in other words, they tend to define all pregnancies as pathology because that's what they know. Midwives see pregnancy as normal, except when it isn't. And because they're so good at normal pregnancies, they recognize abnormal right away, and they're willing to transfer those women to doctors and maternal fetal medicine specialists because the patients need them. So that's my beginnings in that. After about 10 years of practicing and beginning to change and question what I was doing, I decided to start a collaborative practice with 2 midwives in the hospital. Those were certified nurse midwives. There's many different kinds of midwives, and I'm sure that you've probably discussed this before on another podcast, so I won't get into that. And governments are trying to steal the name midwife now from people, so you can't even use the name. But we started another practice in another hospital, and for the next 15 years, we had really good numbers. We had a 7% C-section rate, and the midwives took care of all the normal stuff, and I took care of the complications, and it was a really good relationship. But we were never accepted in the community, and this is very typical of communities where the standard of care hasn't changed in decades, and it's run by a small group of obstetricians who don't like to be changed. They don't like to be challenged. And we were having really much better outcomes than they were. Our C-section rate was 7%. Theirs was 26 or 27%. Same cohort of women. It's just that the midwives took care of the normal stuff and had a very low C-section rate. And I took care of the more complicated stuff. And I still had a low C-section rate because I was learning to practice a midwifery model of care. So after 15 years, they decided they didn't want us there anymore. And they banned vaginal birth after cesarean. Then they banned the midwives. Then they were going to ban breech delivery. It was all just to get rid of us, not because our outcomes were bad, but because, quite frankly, our outcomes were good. And we made the doctors uncomfortable. We made the anesthesiologists and the pediatricians uncomfortable. I wasn't always the easiest person to work with because I thought a lot of what they were doing was wrong and stupid. And I'm known for having a decent sized mouth. So I probably spoke out about it, and I didn't make any friends doing that. And every 2 years, you're up for re-credentialing to be on a hospital staff. And they have the right, like any country club does, of saying that we don't want to renew your membership. And that's what they did. And so I had a choice of fighting them legally, which is a losing battle for most individuals against a major multinational corporation. And by the way, if I would fight them and win, all I'd win would be the right to stay at a hospital that now really mad at me. Or I would lose, which then could lose everything. I could lose my license. I could lose my ability to practice. So I just decided not to renew my privileges. The midwives around me were very loving and encouraging, and they encouraged me to start going to home births. It's funny because after 25 years of backing midwives and working with them, I had never been to a home birth. And that's a big problem of the silos of our profession, is that OBGYNs and maternal fetal medicine doctors have no idea what midwives do. Midwives have an idea because they go with their clients to the hospital, but these people have never seen a home birth. And I had never been to one, but I went to several with midwives. I never went alone because I'm a guy and I have guy energy, and I wanted midwives to teach me what to do and those sorts of things. And I had to sort of learn to subdue a lot of my obstetrical training to just sit back and do nothing. That fine art of doing nothing, which is not something that most obstetricians have, because we are always called into the room or called to do something. We're never called to do nothing. So we don't know how to do that. And I learned slowly over time. And then I became bolder and I said, oh, well, I was doing breeches and twins in the hospital. Why don't I do them at home? And then it was hypertensive. And then it was diabetics. Why do they need to be denied the ability to have a beautiful birth simply because they have a diagnosis that really doesn't affect their labor until it might? If it begins to affect their labor, then they can go to the hospital. But if they don't have to, then they don't need to be in the hospital. Yet the medical model looks at every woman with a diagnosis like diabetes and treats them all the same. Everyone needs to have the same regimented protocols done to them. They need to have this test done, then be induced at 38 weeks. The baby needs to go to the NICU for observation. Doesn't matter if the baby's fine. Doesn't matter if the mother's blood sugars were fine. That's how we treat diabetics. Same thing with breeches and twins. They were getting sectioned mostly. Twins born early, which is pretty normal for twins, because they were born at 35 or 35 and a half weeks. They had to go to the NICU, even if they were doing fine, because they had a policy that said babies born before 37 weeks have to go to the NICU. Does that make any sense? No. But this is how management runs hospitals. They don't trust the nurses and doctors with all their years of training to make proper decisions. They feel that it's safer, more protective against liability for themselves, and actually more lucrative when they put policies in place that generate revenue. And so that's what hospitals do. And that's what I've been fighting now for the last half of my career. And I retired from active birthing in the last 3 years. Time caught up with me. I got tired of being on call. I didn't have any other doctor could do what I did, so I was always on call. Now I go around the world and I teach breech and twin skills. I do meetings on Zoom. I advocate for things like birth choices and midwifery, and I have my podcast. So it keeps me quite busy.
Yeah. I believe you do consult women who are expecting a breech baby that might want to talk with
I
a
deal
doctor.
with practitioners and with women who want to reach out. It's an interesting thing. I don't want to get into legalities of it, but I give advice based on the fact that I have expertise. In some states or countries, the telemedicine was pretty loosened, the laws around it during COVID. And so you can do these things. Eventually they'll tighten it up again because they want to control everything that we do. But for now, that's what I do. It feels good. It feels good to be able to give information to women who are only seeing one side of a story and are being sort of funneled with coercive language or propaganda down a path that the hospital or the doctor wants them to take. If a doctor doesn't know how to do a breech delivery, he's going to tell every woman who has a breech baby a term that is too dangerous. This is what they're going to tell them rather than being honest with them. I'm just another resource that people can reach out to.
Yeah, amazing. That's good. So let's jump into the questions. How many breech singleton births have you attended off the top of your head?
I don't know. But I know that in the last 12 years of my practice at home, it was probably over 100. I published a paper in 2017, I think it was, with Rick Safries from 2011 to 2016 or something. There were 60 breaches, and I had done many more after that. So at least 100. But in my career, I have no idea. I could have easily done 50 breaches when I was at county hospital for those 4 months, but I didn't keep track. It's an interesting thing. Doctors don't keep track. Midwives taught me to keep track. They taught me to keep a logbook originally. And now everything is, digital. But when I first started, I'd get home and I'd write into my logbook, just like my little diary of the birth. The name of the mother, the name of the father, the name of the baby, how long was the labor? What did the baby weigh? What were the interesting things about the labor? I got them all. I still have all the books. When I did my papers, that's where I got most of my data from.
Yeah.
That and the charts. And the charts in those days were all paper charts too. Research is easier now. Electronic medical records have not improved outcomes. They've improved the ability to search for data, but they have not improved outcomes.
Yeah.
So over 100, I would say.
Okay. And so same question around twin. Do you do triplet births?
I've only done one triplet birth in my life, and that was when I was still in the hospital. I never in my 12 years of home birthing did anyone approach me with triplets. I mean, triplets are quite rare.
Yeah.
I think it's about 1 in every 10,000 births, closer, give or take. So it's quite rare. I just interviewed Dr. Hervey from Phoenix on a recent podcast, and he's done 7 sets of triplets vaginally. And what's amazing about that is that, his little hospital doesn't get 7 sets of triplets over 6 years or whatever. People go to him because they get triplets, and then they move to Phoenix and have him take care of them. So it's the same kind of thing. And we had people coming with breeches and twins to relocate into Southern California so that they could have their births with me because they had no choices in the states or other countries they were located in.
Yeah. So my next question is around how many twin births have you attended? So I'm assuming you won't be sure beforehand, but from the home setting, how many did you do it?
Well, in the home setting, the paper that I published with RIXA in December of 2024, it was about 100 sets of twins. And there were probably some prior to that window that we did. So, 100, 150 sets of twins in the home setting over all the years. And then I have no idea, again, in my 28 years of hospital birthing, I have no idea. I would spend 28 years in the hospital and then 12 plus years in the home. So I'm one of those rare physicians who's got a insight into what it's like in both worlds. I said earlier that things are very siloed. So most doctors don't do both. So it gives me a really good platform from which to compare the two models of care.
Yeah, absolutely.
And it's not even close. The two models are not close. The midwifery model with properly selected clients and skilled hands is a much better model for the women, the babies, mothers' future babies, satisfaction, lower intervention rates, higher breastfeeding rates, higher bonding rates, less postpartum depression. Everything about midwifery model of care is the tradition. Got to be careful now when I say that, because I should say traditional midwifery model of care, because as you know, governments are beginning to want to regulate midwives. And I know Canada and maybe even your country have started to take away the word midwife unless you're licensed.
Yeah, so it's the same here in Australia. You're not allowed to call yourself a midwife unless you're registered with the governing body.
Yeah, if you're not registered, you can't call yourself a midwife. It's like, when did the government get control of something that's around long before your Australian government was ever formed?
Yeah.
I mean, midwifery's been around since biblical times and before.
Yeah. So next question, what is the most common breech presentation that you've witnessed at a birth?
Frank breech is the most common. And frank breech is when the baby's legs are folded up by its face. So its hips are flexed, its knees are extended. It's kind of like the diving pike position if you watch the Olympics, when the feet are right up by the face. And it's usually 70 to 80% of breeches are going to be frank breech, generally speaking. At least that's in my experience. If you look in the world literature, it's going to be about 40 to 60%, but generally more than half are going to be frank breech. If we're talking about term breeches, which what we're going to limit ourselves today to mainly talking about late preterm or term breeches.
Yeah. And what's the most unusual situation that you've witnessed at a breech birth?
This question you sent me, and this was a tough one because unusual makes it sound like when you talk about something that's unusual that happened, that becomes the focus, and it's not what we should focus on. But I can think of two. Well, cord prolapse, I've seen. It's rare. It's about 1 in every 250 breech births. You'll see cord prolapse. Cord prolapse is often scary because the cord is sticking out. And if it's a head down baby, that's a real problem because the cord will get compressed by the head and becomes an emergency. In breech birth, although it's slightly more common, it's less emergent because there's more room, thus the cord can fall through, but less chance it's going to be compressed. So I did have a cord prolapse once on a breech first baby, and we had a discussion because the heart rate was fine.
Was it a frank or complete? Or?
It was a complete breech.
Okay.
Yeah. Much more common in complete and incomplete breech. Complete breech, by the way, just for your listeners, is where the baby's hips and knees are both flexed. So the baby's kind of sitting on its legs, cross-legged, like at a yoga studio or something, that sort of thing. And then incomplete breech is where one leg is folded like that and one leg is sticking up by the face. So the baby hasn't figured out which position it wants to be in. And a baby that's in one position today could be in another position tomorrow. Babies don't necessarily stay in any one position. They're rascals.
Yeah, I think I read in the research some ultrasound looking at the presentation, what was presenting at the cervix, it could change every 10 minutes.
Wow. I didn't know that, but
yeah,
it wouldn't surprise, especially earlier on.
So it's interesting around one's being assessed based on baby's presentation, but really we don't know what their presentation will be once you go into labor.
Yeah, you have to kind of give them a chance and wait and see. Right. And that's where ultrasound is useful for doctors who are not good at palpation, but midwives whose skills for palpation are still sharp can often feel a baby and tell you the position of the baby better than doctors because doctors have gone away from hands-on stuff and mostly go into use technology. Why do they do that? Well, it's how they're trained. And quite frankly, you can't really bill for a Leopold's maneuver, which is feeling the baby, but you can bill when you put the ultrasound on her belly. And I think your listeners probably understand what I'm saying is that medical care is a business and The job of those people that run the hospitals is to keep the hospitals financially viable. And if they make more money doing more interventions and they make more money having a C-section rate of 40% than 30%, what is their incentive to do less interventions or lower the C-section rate? You'd think they'd have an ethical obligation to do that, but no, their ethical obligation is to keep the hospital financially afloat. It's very conflicted. The system is so flawed in so many ways.
Yeah.
Anyway, so that's what a breach is, and that's what an incomplete breach is. So the question was, we're still on cord prolapse.
Yeah.
So if a cord prolapses and you check the mom and she's only 6 centimeters dilated, then what we say in America, the ball game is over, and you need to go to the hospital. If the heart rate's fine, you just keep the mom in an unusual position. If the heart rate's down, you put her in knee chest. You might keep your hand in her vagina to elevate the presenting part. You go to the hospital where she gets an urgent C-section. That is the best thing to do. However, if a woman is completely dilated and the baby is reachable, either because the butt is about where you could grab onto it or a leg is where you could grab onto it, and you know how to do a breech extraction, which is part of the things we teach, both my Reteach Breech course and then the Breech Without Borders team, who do great works. We teach this skill. Then you can actually reach up, grab a foot or grab the butt, pull it down, rotate the baby out, and deliver that baby literally in 15 to 30 seconds. When if you decided that you didn't know how to do that and you were going to do a C-section on her and the baby's heart rate's down, it could literally take you 15 to 30 minutes to get that baby out. And by that point, you're not going to have a good outcome. So the fact that my colleagues don't know how to do this because the training programs are not training them how to do this is unprofessional, but it's also unethical and it's just wrong. I mean, OBs are supposed to be experts in all things pregnancy. 5% of term pregnancies have a breech baby or more, whether it's a singleton breech or the breeches with twins. And so you've got obstetricians and maternal fetal medicine doctors who are experts in high-risk pregnancy who can't really offer all options to 1 out of every 20 women that walk in their office. There's several things that really drive me crazy, and that's one of them. That people that are assigned the specialty of obstetrics don't know how to do it. When did we go wrong? Where did we go wrong? And you could look back in the late 80s and early 90s when, for whatever reason, some people wanted to do C-sections for breeches. And maybe they were getting bad outcomes on some breeches, but that's maybe because people didn't know what they were doing.
Yeah.
And so they started sectioning breeches, and then it just made more sense for the system. They felt it was less liability, more revenue, more expedient to schedule a C-section at 7:30 on a Tuesday and be out by 8:20 than to have to take up a labor room for 20 hours while you have a woman laboring with a breech baby. Again, the hospital is not your friend. The hospital's PR department will pretend to be your friend, but the hospital is not your friend. And then the residency programs are just not teaching the doctors the skills they need. The torchbearers for breech and twin and these types of skills are traditional midwives. They're the ones that are going to keep it alive until the pendulum swings back the other way.
And there's seems to be more midwives wanting to breech than what there is OBs.
By far, the courses that Rixa and I teach, I would say 90% of the attendees are midwives or doulas or even other birth workers in the community who just want to know how to advise their friends, family, and clients. They want to know what the data really says. Because if you go to an OB and you ask them about breech delivery, you get this fear response from them. Well, nobody does breech deliveries. Crazy people do breech deliveries. Breech delivery is dangerous. The head will get stuck. This is what they say because they don't know anything. And maybe they've experienced that, but maybe they experienced it because they didn't know what to do. And every obstetrician in sometime in their career is going to experience a woman who shows up in labor with the baby's feet or butt sticking out of the vagina, and they're not going to know what to do.
Yeah.
And so they push the baby back up inside. They have the woman put her legs together. They quickly give her general anesthesia. They cut her open, only to deliver the baby in what position? Breech.
In a breech position.
Yeah, just still comes out of a different orifice.
Yeah.
And they feel safer doing it out of the orifice because they feel if the head gets stuck or something, because they still don't know what the movements are to help get a breech out. They just start pulling on the baby, but they say they can always cut a bigger hole. And by the way, I've seen many women who've come to me with the first baby having a section for breech who I read their operative report and they had to have their incision teed or jade because they couldn't get the head out. Because again, it's the same movements to get the baby out vaginally as it is to get it out abdominally. And they don't know, and they know either one, but they just feel safer doing it that way because that's what the quote standard of care is. And therefore they feel there's less liability to them. What happens to that baby, that mother, and that mother's future babies really isn't on their mind at that moment when they're panicking.
Yeah. I'm glad you said that because a lot of women don't realize that it's the same maneuvers required and the baby still comes out breech when you have a cesarean for a breech presentation.
In some of the articles that looked at breech vaginally versus breech by cesarean, the worst injuries were breech babies born by cesarean.
Mm-hmm.
So it doesn't prevent the injuries you're worried about. It's kind of a facade. It's a false argument. It's a straw man argument. They say it's safer, but it's really not. And especially if the woman wants a second child, because now you've given her the whole VBAC issue, the scarred uterus issue, the whole placenta accreta issue, which is actually higher risk to that second baby than anything coming out vaginally breech is to the first baby. And Sasha, here's the thing. We don't compare the outcomes of head down vaginal delivery to cesarean for head down baby. So we shouldn't be comparing breech vaginal delivery to outcomes from cesarean for vaginal delivery. What we should be comparing breech vaginal delivery to is head down vaginal delivery. And the Royal College of OBGYN has taken a look at this, and they've rounded the numbers, but the risk of a neonatal death with a head down vaginal delivery is 1 in 1,000. And with a breech delivery, it's 2 in 1,000. So think about that. Obstetricians and maternal fetal medicine doctors they don't want you to deliver breech vaginally. They want to section all breeches, but they don't want to section all head down babies. I mean, maybe some do, but they at least haven't gotten any traction yet. So if you section all breeches, you'll save 1 baby. You section 1,000 women to save 1 baby. But what are you doing to those 1,000 women? How many of those women are going to suffer? Theoretically, women, but the rate of death from a C-section is about 1 in 2,200. So for every 2,200 women you do a section for breech, you may save 3 babies, but you'll kill 1 woman. Do you think doctors know this?
I think that's where the language of your risk doubles. They don't elaborate on the actual numbers. It's just, it's riskier because it doubles. And
they use relative risk, correct?
Yeah.
Right. And doing a C-section, the neonatal death rate is 1 in 2,000. So it's actually 4 times riskier to do a vaginal breech delivery than it is to section for a breech. But 4 times a small number is still a small number. And the difference is amazing when you think about it the other way. What's the chance of it not happening? The chance of not having a neonatal death with a C-section for breech is 99.95%. The chance of it not happening with a head-down vaginal delivery is 99.9%. And the chance of it not happening with a breech delivery vaginally is 99.8%. So ask women, what's the difference between 99.8 and 99.9? And people are going to go, not much.
Yeah.
Right. Well, it's double. And the difference between 99.8 and 99.95 is not much, but it's 4 times greater. So when you want to counsel somebody and funnel them down a path that may not be honest, you use relative risk. So women listening, when doctors are telling you it's risky, you ask them how much. And if they say twice as risky, you say, well, what's the denominator? Or you say, what's the actual risk? And I will be willing to bet you 20 US dollars that they have no idea. That's like 30 Australian dollars, I think, isn't it?
Yeah, I can make good money.
No, they don't know because they don't care to know. How can I say this? Because I'm sort of an idiot savant when it comes to breech and twin births. I pretty much read all the world literature on it. I don't necessarily have a good memory for names and other things like that, but I have really good memory for the data on these 2 topics. And I've talked to so many women and so many other doctors over my career, and they just don't know. Some of them care, but can't do anything about it anyway because they work in a system where they're trapped. And some of them just don't even care. When doctors became employees, this was a very bad thing for patients. Because working a shift, you don't get connected to the patients the same way as when they were your patients. And you may know somebody and take care of her for 9 months in the office, and she goes into labor and she's got a stranger delivering her. And the day you're on call, you may be delivering 9 strangers, 9 people you've never met. And it's only human nature to not care quite as much about somebody you've never met before than it is somebody that's closer to you. We all care more about our family than we care more about our neighbors, usually. and we all care more about our neighbors than we care about somebody living in another state. And we certainly probably, as Americans, we care more about our American fellow citizens than we care about people living in Malawi. And we just do. It doesn't mean we're mean or bad. It's just human nature. So what the modern medical model has done, among many things, is destroy the doctor-patient relationship. It doesn't really exist in the model of care that most doctors are stuck in. And look, some doctors are great, and some doctors may do continuity of care model. You have some private OBs and certainly midwives in Australia who do continuity of care. But most doctors work for the government. They work in a clinic. And this has nothing to do with anything we're talking about today, but I had a conversation with my old friend Howie. He was my partner years ago. He's still in practice part-time at Cedars-Sinai. He's been there all these years. We just chat once in a while. And he told me that all the doctors that we used to know and grew up with, they've all either retired or they sold their practices and now just work a shift. And I thought about it for a while, and I thought about the fact that when I was in practice, I had this beautiful office with windows. I had plants. I had carpeting and wallpaper. I had pictures and paintings on the walls. I had my diplomas on the walls. I had pictures on my desk of my family. And my name was on the door. And just recently, some of your listeners may know that I had a total knee replacement. And you're putting your lives in the hands of an orthopedic surgeon who has taken years and years of training to get there. But my orthopedic surgeon, he works in a clinic. So I went to see him for a consult, and you walk into his office, and it's a generic blank office with nothing on the walls, nothing that says it's his office. There's a nameplate on the door that has his name slid into it. And tomorrow his name will be slid out and somebody else's name will be slid into it. And they took doctors who might have been in an era a bit arrogant, but certainly took responsibility for what they were doing. And now you've just demoralized doctors to basically becoming interchangeable parts without anything in that office. If they had anything on the walls, they were like posters about time to get your flu shot or something, not a picture or a painting or a piece of artwork or family members or a nice fern. Nothing. There was nothing there. And these things don't get noticed. Because they happen so slowly over time. But this conversation I was having with Howie made us reminisce for a little bit. And we realized how doctors have been like disempowered and demotivated to actually fight for the patients that they're supposed to be taking care of. I mean, it's very unsatisfying to be with somebody in labor and they're starting to push and now it's 7 o'clock in the morning, you got to go home. So you don't get to see the culmination of your work. I was very blessed because I was always self-employed. So it's a blessing and a curse. The curse was that you're always on call. The blessing was that when someone called you, you knew who they were.
Yeah.
And when you're calling because you're worried at home and you're a patient and you get a stranger on the phone who sounds annoyed versus getting somebody on the phone who you've been your doctor for 15 years, it's all the difference in the world in how safe you feel. But that doesn't seem to matter anymore.
Yeah.
Women need to demand better.
Yes, absolutely. That continuity of care, we know in the research that makes a big difference to outcomes.
Right. You need to demand better. They need to know that listen, you can fire your doctor. You don't have to put up with this stuff. When it comes back on topic, when it comes to breacher twins, if your doctor at 12 weeks finds out you have twins and they're already talking about all the monitoring you're going to need to do and all the ultrasounds you're going to need and probably be induced at 36 weeks or, one of the babies is breached, you'll probably have a C-section. And they're telling you this at 12 weeks. What are they doing? Just vomiting their anxieties and fears upon you. So now instead of enjoying this wonderful event, you are now worrying for the entire 9 months. And the same thing with breach at term. The minute they find out you have a breach at 32, 33, 34 weeks, they already start to groom you for a cesarean section.
Yeah.
And grooming is the right word. They don't necessarily tell you your options.
Yeah.
They only tell you the options that they're
comfortable with.
Right.
Yeah. All right, let's jump back into the questions. So the next question I had, this was from one of our listeners.
This is going to happen.
That's
this
all
is
right.
just who I am.
I know.
Sorry.
I've been to your class. How common is it for breech babies to need or receive oxygen or breaths at birth? Could you explain why this would happen?
One of the things that's common in every single paper on breech, no matter who wrote it, is that breech babies tend to have lower 1-minute APGAR scores. And that's because they come out a little bit more floppy. And, in a conversation with Barbara Harper, the water birth guru person, I kind of got an idea of sort of why that happens because babies don't take their first breath until their face is exposed to the outside air pressure and oxygen and air. And because the babies are already, the head is still inside and comes out last, it wouldn't be surprising that they're starting the 8-ball a little later than their head first compatriots whose head sticks out first and they already start to plan on breathing sooner. So it's not that uncommon. And all the papers that find this lower 1-minute APGAR score stuff find that by 5 minutes, there's no statistical difference. And then they followed these babies up to 2 years of age and found no neurologic difference between babies born breech vaginally and babies born by cesarean for breech. So it is not uncommon. Oxygen is something we really don't use much anymore for resuscitation. It's not part of NRP. We use room air. And most babies will come around on their own within the first 60 seconds. But if a baby looks really floppy and is not really responding, then everybody's at a birth is well trained to know what to do for that baby. And those babies generally come around fairly quickly. If their heart rate has been good in labor, then they're likely to come around real quickly. If they've been having problems in labor and problems in the second stage and pushing, where you're hearing the heart rate kind of drop and come back up again, those babies may need a little more resuscitation. But again, I've never been to a birth with a midwife who isn't prepared. In the hospital, they have a button on the wall they can push, the whole Pete's team comes in the room. But at home, your midwife's already got all her resuscitation stuff on a little tray. Maybe you haven't seen it because she's got it covered with a towel, but it's there and she's ready to go and take care of your baby if need be. But yes, breech babies tend to come out a little floppier. That doesn't mean some breech babies don't have APGARs of 9 and 10 or 9 and 9, but generally the first APGAR is going to be statistically lower. Rix and I found that in looking over my data as well. But by 5 minutes, there was no statistical difference in APGAR scores between vaginal and cesarean, or between head down and breech babies born vaginally.
Yeah.
By 5 minutes. So I think that answers that question.
No, that's great. Thank you. This is from a listener. Do you have any experience supporting women with a known bicornuate uterus? If so, what have you observed and what should these women be aware of if choosing a vaginal breech birth?
Okay, so bicornuate uterus is not uncommon. At least, I mean, some sort of uterine septate anomaly is not that uncommon. Maybe 10, 15, 20% of women may have it as far as we know. Sometimes it's subtle. You don't even know it. A woman would never know it. So I've encountered it many, many times. And one of the things with the septate uterus is the baby is more likely to be breech because for whatever reason, once the head's up there and those septum's in the way and the baby can't flip around, and so it stays breech. So it's quite more common. I can't give you a number, but it's if 3 to 4% of term pregnancies are breech, probably at least double or triple that of those babies are going to have mom with a septate uterus. I've had several women that have had 3 or 4 breech babies because they've had a septate uterus and they've had them all vaginally. We had one mom that had 5. I didn't take care of her, but I got to meet her at one of the breech conferences. Yeah, so she had 5 vaginal breech deliveries. Pretty darn cool. With a midwife.
That's amazing.
Pretty much.
Yeah.
Yeah, because doctors aren't going to generally go for that. It's a very common thing. It's not usually significant. Small increased risk of preterm labor over the general population, but you wouldn't do anything different for a woman until she's had a problem. So when a woman has a septum, you don't say, oh, you have a septum. We should resect that septum before you try to get pregnant. That's a mistake because one, many women with septums have term pregnancies. 2, the surgery can cause scarring in the uterus, which can cause fertility issues. 3, I have personal knowledge of women who have the ultimate septum, which is called the uterus didelphys, where they have 2 uteruses, 2 cervixes, just a fallopian tube on each uterus and an ovary. So they have 2 fallopian tubes, 2 ovaries, but they also have 2 uteruses. So the septum comes right down the middle, and then sometimes it goes into the vagina and causes a vaginal septum. But you actually put a speculum and you can see 2 cervixes. Those women can have term pregnancies. We just don't know. So it's an approach that your doctor or your caregiver should take to be honest with you, but also remain positive and not fearful. And I hear too many stories of doctors who hear that, who then are telling the woman all the things that can possibly go wrong. And that's why we're going to give you baby aspirin. We're going to put you on progesterone. We're going to have you at bed rest. We're going to monitor your cervix with ultrasound and stuff. None of that stuff has been shown to actually make a difference if you have never had a problem. If you've had a couple of miscarriages and it's been unexplained, one of the things you might want to do is have someone take a look at your uterus because a lot of times it's missed until it isn't. Breech is more common with a bicornuate uterus or a septate uterus, but head down babies are still the most common scenario, and head down babies at term are still the most common scenario. Yeah. And you can't, predicting anything in life is hard, but predicting obstetrics is really stupid. You should try to do that. That's why we don't think due dates should even be discussed anymore.
So another part of this question also is, why are these women limited in their options for a vaginal birth? So do you think it's just because they end up with a breech baby that it's automatic, we recommend a cesarean?
Any doctor who recommends a cesarean for a woman with a septate uterus before they're at term and know what's going on is not a doctor I'd ever want to go to. There would be no reason to do that, to make that recommendation, other than to project their anxiety upon you, and now you suffer with it for the entire pregnancy. We just don't know. But a bicornuate uterus is not an indication for cesarean section in anybody's textbook. So no, cesarean section is not something you should have just because you have, I hate the term, but just because you have a uterine anomaly. Okay. Yeah. I mean, we used to call them uterine variations or whatever, because the anomalies just sounds bad. And because it's fairly common, it really isn't something that is that unusual. The question we should ask ourselves is it more common now than it was 100 years ago? And if so, what are we doing that's causing it? Are we taking, are there hormone blockers in our food when we're developing our fetus inside of us, or where our babies are little, or they're little girls? And we know that there's microplastics and all this stuff in our food. But again, is anybody looking to see if we're having more of these things because we're doing something, or is it the same rate as it was 100 years ago? Because that's not something that should change based on evolution or anything like that in 100 years. But it certainly can change because of what we're doing. Just like placenta accreta, which is the placenta growing into it. Prior to 1960, it wasn't even really in the textbooks. And when the C-section rate was 5%, it was like 1 in 1,200. Now, with the C-section rate at 30-some%, accreta is about 1 in 270 pregnancies. So there's a direct correlation between rising accreta rates and rising cesarean section rates. But is there a correlation between maybe rising rates of uterine abnormalities and what we're eating or what we're doing or what's in the spraying in the air or what, all the other stuff that's going on? We need more interest in research to do that. These studies are not easy to do, though, because how do you get a control group?
Yeah.
What are you controlling for? It's not something you can easily do, but you could certainly look at, historically, you could just do a retrospective review and look at the numbers. It's hard to search that out. Any one of us could Google search that, and you wouldn't find an answer. It wouldn't be clear. So you'd have to really do some diving. You have to look at some old textbooks and things like that, which are not easy to do. And then again, since there's no money in it, who's going to sponsor it? Who's going to sponsor research like that?
Next question. What are your top tips for women planning a vaginal twin birth?
Have no fear. Find a skilled, confident practitioner. Find somebody that when you go in and talk to them and you discover you have twins, that you walk out of that appointment feeling better about yourself than feeling worse. Those sorts of things. Twins generates a lot of fear in the medical world. And fear isn't the right response. Respect is the right response, because there are things with twins that can go wrong. In my experience with my paper, we had 100 women that came into care with twins, and 31 of them were transferred antenatally prior to labor for problems. So that's 31%. And the most common problem is going to be preterm labor or premature rupture of membranes. But there's higher rates of preeclampsia. There's higher rates of diabetes. Again, higher rates does not mean high risk. It just means there's a higher chance of something happening. Cholestasis of pregnancy, other issues that women got transferred for. And by the way, in our paper, which maybe you'll put in your show notes,
Absolutely.
we have tables of why these women got transferred. You can kind of see why each woman got transferred out of care antenatally. So there are issues with twins that make it more likely that you're not going to make it to term. So find somebody who's comfortable and confident with twins vaginally. And that's going to have to be somebody who's comfortable in breech delivery. So one of the things that you can do even before you're pregnant is, you can check out your local hospital and talk with the local doulas, maybe some of the labor and delivery nurses, ask them about the doctors that work there, and find out which are the good ones. Find out which are the ones that maybe support VBAC, support breech, that do twins vaginally in your community. If there's nobody in your community, then you might have to drive to a different community for your prenatal care and your birthing. I mean, one of the things I talk about unfrequently, Sasha, is when people move, when you've got a family and you move to a new community, I mean, the first thing you probably do is check out the schools. You check out the parks. You check out where the market is. Check out the crime rate. You may check out the noise pollution, or where's the Bluetooth towers, that kind of stuff. But one of the things that people never check out is, like, how good is my hospital? What's their C-section rate? What do they do if you go past 40 weeks? What happens if I break my bag of waters and I'm not in labor? Can I bring whoever I want into the labor room? Can I eat my own food? Can I go without being monitored? Ask these questions long before they become imperative, because now you're 37 weeks and you've forgotten to ask them beforehand, and see what kind of answers you get. And if the answers make you feel comfortable, that's a really good fit. And if they don't, then you don't have to sit there. It's kind of like if you go to a restaurant and you order your steak medium rare and it comes back well done, you could either send it back, you could say nothing, or you could never come back to that restaurant. And you probably wouldn't come back to that restaurant again, or at least you wouldn't come back and order steak again. But yet we get mistreated in the hospital and we just keep coming back for more. Finding a comfortable practitioner, because twins are hard right now to find somebody who's feeling good about it. But if you look hard enough, there are places and people who are still good at that. Much depends on the type of twinning you have. The term is called chorionicity. And when you have twins that have their own chorions and own amnions, those are called di twins. Those are twins have the least amount of risks involved with them. Then you have what's called monochorionic diamniotic twins, which are identical twins. And they share a placenta. And sometimes there's a mixing of blood and products between the two of them that can lead to significant problems. Those babies need closer surveillance than di twins do. And then there's something called mono twins, where the two twins are in the same sac. And there's a routine treatment for that actually, if they look at the minimal literature on that, because it's very rare, everything that they recommend for that type of twin is wrong. My colleague David Hayes, who formerly at Breach Without Borders, some of you may know him, did a deep dive into mono twins and found some crazy information. Even though I don't want to spend much time on it, because most of you will never see a case of this, because it's pretty rare. It's 1 out of every 300 sets of twins, or about 1 in every 10,000 births. So that's how rare it is. But it just is another example of how the medicalized model gets stuck in a habit way of doing something and then doesn't want to change, despite what evidence shows to the contrary. They won't change. And so the same thing goes with mono-di and di-di twins. There are certain protocols that are put out there, and they'll treat every set of mono-di twins the same, even though some of them will be with no complication whatsoever and can be left alone and don't need to do anything. They will still tell you that they need to be born by 36 to 37 weeks, which means you need to be induced or sectioned. Babies are coming out before they've decided they're ready. Some of those babies, a higher number, are going to end up going to the NICU for a little while, and all the complications that go along with that. What we found with twins is when problems develop, you can pretty much pick it up with good surveillance. When they don't develop, there's really nothing different about twins than singletons. There's a slightly higher rate of postpartum hemorrhage and other things like that. But as far as the growing of pregnancy and the going into labor and the delivering of one baby, and then, oops, there's another baby in there, it's not something that needs to be that worried about. Again, my colleagues tend to make it into more than it is. Partly it's a psychological technique that helps quash or quell their anxiety. By passing that anxiety on to you, they've sort of dispersed their own. So again, the number one thing, finding a confident, comfortable twin provider who feels comfortable with breech delivery. Because over half of all twins will have at least one of the twins in the breech presentation. So if you have a doctor who likes twins but says they both have to be head down, that's not a doctor that should be doing your twins. Because more than half the time, one of your babies will not oblige him or her. And therefore, you will end up with a C-section. Even if you deliver baby A head down, B was head down, but then baby B flips to sideways or breech, now you get a C-section instead of a skilled practitioner who can reach up and turn the baby or pull the baby out if necessary. So find somebody who's skilled with those skills. Breech extraction, feels comfortable, not pushing the issue. Ask them how they do twins. How long do you wait between twins? Do you induce? Do you let moms go to past 40 weeks? Why? Why not? Ask the questions. Again, I don't expect anybody to know all this information, but Rixa did a really good job in our paper on 100 sets of twins that we talk about all this stuff in the discussion section. So you may not remember what I'm saying now or anything, but it'd be really a good reference to pull the paper up. It's open access. It's free. It's called Home Twin Birth, Outcomes of 100 Sets of Twins with a Single Practitioner, something like that. I'll give you the link.
So next question is around research. So you've shared that one a couple of times. You've just mentioned Dr. Hayes. He's looked at mono. Has he actually published anything on that, or it's just something he's looked at?
No. There's only one study that's published. The other study was a preprint, and I actually spoke to the author, and she said she wanted to publish it, but it got quashed because it went contrary to the narrative, which is not an uncommon thing in research these days. If they go contrary to the narrative or they go against the sponsors of the journals, they don't get published. So, but the one that's published is by a guy named Diaz. I can send you the link to that too.
Yeah, that'd be great.
And Candewalls, I think you can find a preprint still online, and I have a link to that. I'll give you all these references in an email when we're done.
Thank you. Next question. This is from a listener. Could you please explain twin-to-twin head with Everett entrapment, but I believe it's the interlocking? How common is this? Because I think this is something they've been told, with baby A being breech, baby B being head down.
Well, that's standard teaching in residency programs. If baby A is breech and baby B is vertex, that you can't have them because the heads will get stuck. That's not what the world literature says. The largest studies by a guy named Abaram and a guy named Blickstein over the last 25 years have looked at breech first twins down to 1,500 grams, by the way, which is 3 pounds, 5 ounces for those of us in old-fashioned system. But 1,500 grams is like a 31-week twin. And they found that there's no improvement in outcomes for sectioning a breech first twin that's higher, that's above 1,500 grams. There's no obstetrician that would know that, and nor would any obstetrician let you have a 32 or 33 week breech first twin vaginally. They just won't do it. Part of the reason they won't do it is they don't do breech anyway. And part of it is they'll use the excuse that the baby's heads could get stuck on each other. So the incidence of that is extremely rare. None of the major studies found any incidence of it at all. So lo and behold, for me, I believe that. I didn't expect it to happen. I thought I had a perfect client I thought it might happen in, but I thought, nah, the Blickstein guy, he said that doesn't happen. It's not going to happen. And then, of course, it did happen to me. And I wrote a case report on that because I thought it was really important that people understand how to resolve that. It's not a reason not to let a woman have a vaginal delivery with a breech first twin. It's a reason to have skills to know what to do in that case that happens. And when it happened to me, again, I'm making it sound like it was very casual. There was a lot of tension in the room, believe me. But what you do whenever something seems to be stuck is we use the analogy that Rixa came up with, which is like the spoon in the kitchen drawer. If you can't open the kitchen drawer because there's a spoon stuck in it, you don't keep pulling on the drawer. You push the drawer in and then you move something around and then you open the drawer. It's the same thing when a baby is breech or there's a baby that seems like the head was stuck on the other head, is that if the baby won't come down anymore, you don't start pulling on the baby. All you're going to do when you pull on a baby is injure the baby, hyperextend the neck, cause problems. What you need to do is you need to take the baby and you need to take the other baby and you need to put your hand inside and push them up. And as the pelvis widens above, there's more room. You can push the one baby that's head was down lower up past the first twin, and then the other twin just comes right down. And you can do that. It's again, talking about it makes it sound like it's just an easy thing to do. It actually was easier for me simply because of my years and years of hands-on breech training and my idea of the spatial relationships of what's going on inside, partly because of the continuity of care model, because I knew this woman and I knew her twins. And I'd been the one following her twins with ultrasound in my own office because I did my own ultrasound. These things are rare. You don't see them anymore. Doctors like me, they just don't exist much anymore. But I knew that baby B had been breech for a really long time. And so baby B formed what's called a dolichocephalic head, which is a very oval head because it's the shape of the fundus. And for whatever reason, a week before she went into labor at 37 and 5, I think, or 37 and 6, baby B switched to head down. So its head was down and it was lower than baby A's head, but I just assumed that baby A would slide right on past. But I was mistaken and it didn't. And so that's where they got stuck. So I just pushed them up and I pushed baby B's head up and then baby A's head came down. And then baby B came down head first later. So it can be done. It's extremely rare and it is not a reason. The world literature does not support sectioning breech first twins. There are papers that say that don't allow breech first twins, but that's because they're doing studies on twin vaginal birthing and they didn't want to put that in the mix. And the argument they'll use is the interlocked head issue. But in studies that looked at breech first twins, they didn't find that as an issue. And they found that that's not a reason to deny a woman the option of a breech vaginal delivery if twin A is breech, of a twin vaginal delivery if twin A is breech. So I hope that answers that question.
Perfect answer, and great to hear that you've actually even had that experience in how you managed it, to give any practitioners that might be listening an idea of what to do if that happens.
And I thought it was so important that I tried to publish a paper. And again, I couldn't get it published in any of the American mainstream journals. I tried. I had a conversation with the editor of the Green Journal, which is ACOG's journal. She was very kind. She was very kind to me. She just said, Stu, they're not ready for your stuff. Yeah, that I wouldn't be able to get something like that through peer review. And by the way, the article is written so that it's not, there's no way you know that was a home birth. Doesn't say anything in there about a home birth. Just describes the birth. It describes what happened, but the location was irrelevant.
Yeah.
But if I put there that it was a home birth, it would be completely ignored and dismissed immediately. People would just say, well, that crazy guy who does twins at home, because that makes them feel better. Because they won't do it. And they won't offer a woman that, or they won't offer a woman the advice that says, listen, I can't do it, but there's that crazy guy. Why don't you go talk to him? I mean, you can't do that anymore because I'm not practicing, but there are people and there are midwives around the country who will do twins vaginally, including breech first twins. And they know exactly what they're doing because they've taken the training, which is B residents have not taken the training. They just don't get it. Breech Without Borders gets into maybe a couple of hospitals a year to do some training. So it's a start.
Good. Yeah.
As a start, you have to start someplace.
Absolutely. All right. I've got 3 more questions, all from a listener and specific around VBAC. You've kind of touched a little bit on it already. So her first question was, what are the risks a woman needs to consider if wanting a VBAC versus a repeat cesarean? Well,
that's a personal decision. Of course, it depends on, do you want a third baby? That should come into play. because if you have a second cesarean section, you put yourself and the third baby at greater risk than if you try to have a VBAC. It depends on what the reason was for your first C-section. There's all kinds of variables, but let's just assume that you would be a good candidate for a VBAC. So the downsides of VBAC are that there is a small chance that the scar can separate, and the word for separation of a scar is called dehiscence. And on rare occasions, the dehiscence becomes what's classically called a rupture. Rupture is not a good word to describe what mostly happens because rupture conjures up the image of a tire exploding on a freeway from a semi. And that's not generally what happens. It happens rarely. How often does it happen? Well, after a single low transverse C-section, if you look at the world literature, it's somewhere between 1 in 200 and 1 in 333. Women who try to labor will end up with a uterine scar that separates. So let's just take 1 in 200 because it's the bigger number. Then you ask yourself, if the scar separates, how often does the baby suffer? Terribly. And by terribly, I mean terribly, like brain damage or death. And the answer is somewhere between 5 and 16% of those babies will suffer a terrible outcome, depending on which papers you look at. So let's take 16% because that's the bigger number. So 16% is about 1 in 6. So the actual risk from any woman just thinking about doing a VBAC is 1 in 6 times 1 in 200 or 1 in 1,200. That's the risk. So it's less than 1/10 of 1%. But if it's you, it's 100%. And for the other 99.9% of people, it's 0. But you can't predict who it's going to be. And there is no way to predict who's going to rupture their uterus in a bad way. VBAC calculators are useless. Some doctors will rely on them because they like objective stuff. So they'll take a VBAC calculator and they'll put in the scar thickness and how long it's been since your last C-section and size of the baby and how old you are and whatever. And it goes into this little calculator and comes out, you have a 42% chance of success. That's wrong. That doesn't work. And it's been abandoned in most places. So if your doctor's still using a VBAC calculator, it's because they don't want to support VBAC generally. It's a way to talk somebody out of having a VBAC. So that's the real risk. The risk of a cesarean section, a second cesarean section, obviously, because you've already had one, is all the risks of surgery, which again are small, which include hemorrhage, adhesions, scar tissue, pain, bowel obstruction, bladder injury, future ruptured uterus, future placenta accreta. I probably left some out, but those things all have to come into play. And then also you have to think, what's better for the baby? Is the baby better off delivering from a repeat C-section or from a vaginal delivery? And if you trust nature's design and you look at populations in general, again, what's going to happen to your individual baby, we can't say. So we look at statistics. But your baby is better off delivering vaginally as nature has designed. It's better for the baby's immune system. Babies have less chronic illnesses, less autoimmune diseases, less respiratory problems, better bonding, better breastfeeding rates. And then the mom has better bonding and breastfeeding rates, more attachment to their baby. Many women will say, especially women who had an emergency C-section under general anesthesia, I can't tell you how many times, Sasha, I've heard the term, I have a baby, but I didn't give birth, or I have no memory of his birth. And a lot of times when the general anesthesia they use, they don't let the father in either. So here's a baby born with no parent witnessing its birth. And we just interviewed a practitioner of pre and perinatal psychology on our podcast and sort of blew me away about the experiences that happen to you in utero, what's happening to your mom, what's happening in the sounds you hear, whatever's going on in utero, how you're born, how it affects you later on. And I can't help but think, again, these are all theoretical things that are kind of beyond me because I have a left-sided scientific brain, but I was born to my mother who was given twilight sleep and I was pulled out with forceps. So my mother also has no memory of my birth. And her attachment to me came later because they had probably already taken me to the nursery by the time that she woke up. So my mom and I had attachment problems my whole life. God rest her soul. But we did. Could that have all stemmed from birth? I don't know. I don't want to make an excuse for that. I could have done things better as a son. But nonetheless, how we birth matters. So try to avoid that first C-section so you don't have to have the VBAC discussion. And that's by, again, finding a skilled and willing practitioner to give you the best odds to deliver vaginally. And that is not going to be in the standard medical obstetrical practice. Most standard OB practices have 30, 40, 50% C-section rates. Your C-section rate in Australia is now over 40%. It's crazy. When 50 years ago, it was 5%. And the outcomes for your babies have not gotten better. So what have we done? What are we doing? And why are we letting these people continue to guide us into the future of obstetrics? This is the definition of insanity. Doing the same thing over and over again, or even adding new things that haven't been tested over and over again and expecting a different result and not really looking at your outcomes and saying, geez, all these technologies that we're doing, all these things we're doing, and our outcomes are not getting better. The only thing that's gotten better is generation of revenue.
Yeah.
And that's sick. And it makes me angry. And what we've denied mothers and their babies, the birthright that they deserve in the name of health, really? Our babies have never been sicker. Our children have never been sicker. We can blame many things on that. The beauty of having many things to blame is that no one has to take any responsibility. Is it glyphosate? Is it 5G? Is it geoengineering? Is it the heavy metals in our environment, our sprays, our vaccines? Is it the way we give birth? Is it the antibiotics we've given to babies or mothers when they're in labor? It could be any of those things. No one's looking. That what we're doing is making some people wealthy, but it's not making outcomes better. And it's time to change that. And the change is going to have to come from the individual families. They're the ones that are going to have to demand the change because the system is too happy the way it is right now. They're not going to suddenly admit that they've been wrong all this time and then just walk away. They're going to double down. Your organization, RANSCOG, and mine, ACOG, they're still pushing the COVID vaccine, the flu vaccine, DTaP vaccine, and RSV vaccine to pregnant women, none of which have ever been tested for safety in anyone, let alone a pregnant person, and never at the same time, given 3 or 4 or 5 antigens at the same time. Yet ACOG, and I'm sure RANSCOG says, well, you can give the COVID vaccine in any trimester in pregnancy. Well, where's the data on that? There isn't any. If there's any data at all, it's detrimental, and they just ignore it. You have to ask yourself why.
All right, so we'll keep going on the VBAC. So laboring at home, is it safe for VBAC? When is a good time to go to hospital?
The fallacy is that if you have a ruptured uterus in the hospital, that you're going to have a good outcome. And the answer is it's very unlikely that you're going to have a good outcome. If you truly rupture your uterus, if you're that 1 in 1,200 that I mentioned earlier, and you have a ruptured uterus, you're not going to have a good outcome, almost never. So the idea that you're going to go to the hospital where you have a very poor chance of success with a VBAC, and that's statistically proven, that success of VBAC at home is much higher than the success of VBAC in the hospital. And that's simply because of the model of care. At home, you're being left alone. As mammals are designed to labor, you can eat, you can walk around, you can get in the shower, you can move, you can have people in the house that you like, you can tell everybody to shut up, you can kick everybody out, you have control of your space, you're in the place where you feel safest, you can be walking around naked in your house. It's how primordial it should be. When you go to the hospital, everything changes. So your chance of success is lower at the hospital. For those women that understand that and still they're not ready to have a VBAC at home, try to stay home as long as possible. And the way you can do that is to hire a doula and maybe even have a midwife as a monitrice, which is somebody that can actually come to your house and listen to the baby, check your vital signs periodically, maybe do a vaginal exam. And if you feel like you need to go and you're only 4 centimeters, don't go. Because if you go at 4 centimeters, you're going to be given the cascade of interventions and you're going to end up with probably a repeat C-section. So you want to show up when you're ready to push. So there's less time for them to actually try to start an IV and interrupt you and push an epidural upon you and all the things that they do. And eventually the baby's not going to like your blood pressure dropping. And then your labor spaces out. So then they start Pitocin. And then your baby doesn't like it even more. And they think your baby's in trouble. And you end up with a C-section for, quote, fetal intolerance to labor, when it really is fetal intolerance to augmented labor. And that's a whole different ballgame. Now, I know that people listening are going to say, this guy, he's so anti-hospital. And the truth is, I am for normal stuff because the hospital does it poorly. How do I know that? Because I worked there for 28 years. Spent a long time there. I worked at many different hospitals over my years. I saw the same stuff going on and I still see it to this day. And then I've also experienced the home option and I've seen it differently. So again, hospitals are really good at taking care of things when they're really bad. And they're very good at making good things go bad so that they then take care of them. But they're not good at leaving people alone. They're just not. And unfortunately, the hospitals need the normal births in order to financially stay open. And we need them to stay open because we need them for the problems. Hospitals are going to need to learn that if they want to stay viable and they want to stay open, that they need to let pregnant women come in and do their own thing. And then if they need help, they can have help. And then change some of the laws so that trial lawyers can't just be suing everybody when there's an outcome that isn't perfect, because otherwise you're getting, the reason we have where we are right now is because of all the interventions like fetal monitoring and labor curves and fear of litigation that have driven the C-section rate to where it is right now. And until you resolve those things, nobody's going to start suddenly backing off. So VBAC at home is safer, better outcomes for most women.
Yeah. You've pretty much just answered the next question because the next one was, is home birth completely out of the question for a VBAC? So you've just said it is safer. I guess it will come down to the individual practitioner.
An individual woman's where she feels safest.
Yeah, exactly.
I think you know this, Sasha, that a woman should labor where she feels safest. And the facade has always been that the hospital is a safer place. And maybe during this hour, we've broken some of that. I'm sure I'm not the first person who's been on your podcast who said these sorts of things. I just truly believe that birth is not an illness that requires hospital treatment until it becomes a medical condition. And most of the time it doesn't. And the hospital is really good at making people nervous. And when you're nervous the entire 9 months, what is that doing to you, your partner, your other children, and your developing fetus? If you're constantly being bombarded with things that make you nervous, and that's just the way the medical model works, they make people nervous. So it benefits them, by the way. The more nervous you are, the more pliable you are, and the more likely you are to submit to the tests that they can run that generate more revenue for them. I did a consult with a woman today on the East Coast of the United States on Zoom. And she is pregnant with mono-di twins. And I think she's just about 36 weeks tomorrow. She's had 16 or 17 ultrasounds. Every single one of them, she had color flow Doppler turned on. I can't tell you what the bill for her ultrasounds would be. And this is at Yale. Yale is like, the institution. This is how they manage mono-di twins, who are, by the way, 3% discordant and both over 5 pounds estimated fetal weight at 36 weeks. They're doing fine. And she's had 16 ultrasounds.
That's a lot.
Not to mention how many NST and biophysical profiles and fluid checks and other things, because she's on the mill. She's got mono-di twins. This is how we manage mono-di twins. Even if they have perfect ultrasounds every time, we're not going to say, no, we have to stop doing it. At some point, you could back off, but they don't. They create more problems. She reached out because someone told her that maybe she doesn't need all this stuff, and she just didn't know where to turn. And how does an individual stand up against Yale or Harvard or Johns Hopkins or Oxford or any of these other famous places where just the name is supposed to instill credibility? They really think they know everything, but they really don't know much of anything when it comes to twins. They're always looking for a problem. And so they're projecting upon the women who have breech and twin babies and even VBACs, previous C-sections, that their pregnancy is a problem. And what is that doing to her? Pregnancy should be a time of joy.
Let's wrap this up. Do you have any last words of wisdom or advice that you'd like to give to our listeners that have a breech baby or twins?
Yeah. The one thing I would always tell women, no matter where you decide you want to give birth and with who, like if you want to give birth in a hospital with your National Health Service physician, that's your choice. But try to pay out of pocket for a midwife and have 2, 3, 4 prenatal visits scattered throughout your pregnancy with a midwife. Your visit's going to be an hour and a half long. You're going to be able to talk about things that your doctor is saying, and that midwife is going to be able to bring you back on course. You've steered away over here to the right. We want to bring you back to the center. You've steered over here to the left. We bring you back to the center and ground you so that you have people around you that can tell you with no dog in that fight. They know they're not going to be at your delivery. They're not making a fortune. They're getting their like $150, $200 for their hour and a half consult with you. And they're going to be as honest as possible to keep you calm and relaxed and give you the ideas and questions to ask your doctor so that you know what to ask. Because we do have this authoritative challenge going on where the doctor has the white coat. She has got all these degrees behind her name. And who am I to challenge her? I'm a local barista. You know what? You're the one that's pregnant. You have the right to ask questions. And if they don't want to answer your questions, then either find somebody who will, like seeing the midwife, or change practitioners. Change your model of care. Support traditional midwifery. They need it. They keep the flame alive of these skills. It's not going to be your certified hospital midwives that are going to continue with breech and twins that often. They're going to get squeezed out of it by their medical colleagues. Our future generations deserve better. If we keep going like we're going, within another 2 generations, the C-section rate will be 80%. And
No, thank you.
If you want to see a species change, when you're meddling with nature's design that brutally, there is going to be repercussions. You're going to see ripple effects downstream. And maybe the world is so detached right now because of the way we've been giving birth over the last 50 years. I mean, there's more to it than that, but that may be part of it. Do we think there's not going to be a downstream consequence? This is the stupidity of the modern medical obstetrical world. They're so in a box, they can't see over the walls.
Yeah.
I think I beat that horse to death. And I'm sorry if I talked over you.
No, you're good.
I have passion for this subject. And even though I'm recovering from knee surgery and I'm still hurting a lot, it's hard for me to sit for an hour and a half. This was not hard at all.
Well, thank you so much for coming on. I really appreciate your time.
You're welcome.
The Breech Birth podcast is independently created and produced. If you'd like to support the continuation of this space, you can do so through Buy Me a Coffee. Your support helps keep these stories being shared and accessible to women and families around the world, and you can find the link in the show notes. Thank you for listening to the Breech Birth podcast. These stories matter. They stretch what we think we know and bring voice to experiences that need to be heard. I'm so grateful to our guests who have shared their experiences with us, raw, real, and full of wisdom. If this episode resonated with you, please subscribe and share with others. You can find us on Instagram, Facebook, and YouTube at Breech Birth Podcast. And if you have a breech story to share, I'd love to hear from you. Until next time, may we continue to reclaim the narrative one story at a time.